NHS. We're joined in the studio by Dr. Una Coles, and in central London we have the GP Yusuf El Ging. Oh, you're going to have to pronounce your surname for me. Apologies.
El Gingi.
Thank you very much. Apologies for that. I'll come to you first, Dr. Una Coles. Now, this is quite extraordinary that one example we're hearing of, £125,000 in 3 months. How can that be justified?
Okay, it does sound astounding, but we have to ask, well, who is this doctor? Are we talking about a foundation year doctor? Unlikely, because their cap is at £18 an hour. Are we talking about a consultant? Now, a hospital consultant in A&E, you'd think, oh, well, they deserve to be paid £500 an hour. But actually, the NHS cap is £70 an hour. So if some doctor has accumulated £128,000 in 3 months, I'm thinking, are they working day and night, every day, solid and night for 3 months? I mean, how is that possible? Because those are the cap prices. When there are breaches of 250,000 cases, that is allowed if there is a legitimate patient safety concern. And we're talking about paying an A&E consultant £90 or £78, and that's a breach because they've gone over the £70 cap. So I think it's a bit far-fetched to say, oh, here we've got this one doctor who's made this incredible amount, and I don't know how, based on those caps, and say that that's indicative of everyone else. It's not. The breaches are very minimal. I mean, a foundation doctor or a junior doctor caps are at £25, so if they get overpaid by, they get paid £30 an hour. That's a breach. So,
Dr. El Gingihi, these caps are there for a reason. They are to stop the NHS from overspending on locum doctors. How are they being breached so easily, it seems? What's the point in having caps if you're just going to breach them?
I think the locum cap remedy, which was introduced by Jeremy Hunt, is really a cosmetic solution. It doesn't deal with the root causes. The root causes here are quite simply that insufficient numbers of doctors and NHS staff beyond that are being trained at medical and nursing school, and we need much better policies beyond that for better recruitment and retention, essentially. So I don't think NHS hospitals and employers or GP surgeries are choosing to pay for locum doctors or locum staff out of fun, really. It's because they simply haven't got the numbers to run a good quality service.
Something that struck me, Dr. Coles, in our report was the fact that locum agencies, are taking a huge cut. They're taking about 30% quite often, aren't they? And of course that pushes the price up. So it's not even always the doctors taking all the money, because agencies are involved as well. Is that a good thing?
no, that's exploiting the NHS. So what some hospitals, especially in London, are doing, because they are trusts and they have a larger pool of staff, is creating their own hospital bank, and therefore they're able to pay at around the cap. So you'll see that in London the cap will probably be working, but outside London the hospitals are smaller, the staff are limited, and trying to get staff to come work extra shifts or what have you, that's harder, so they're going to be breaching the cap.
We've even heard cases of doctors or agencies playing trusts off each other, to see who's going to give them the biggest price.
That's true. Well, now trusts have instigated a rule that if you have a substantive job in a trust, you can't do locum moonlighting in another trust. They want to keep their doctors doing extra shifts in their trust, and so hopefully that will help.
Dr. Yusuf, does this come back to the junior doctors debate, do you think? The fact that, you've got people in their last year of med school already plotting an exit strategy, as I was told, if they could go to New Zealand or Australia, anywhere but going to the NHS because they're not treated very well and they could get paid more elsewhere. So you get this brain drain.
Yes, I mean, exactly. When we look at the actual policies that are being implemented, we've seen the new junior doctor contract, which led to a year of industrial action, and it's been hugely unpopular for good reason with doctors. And as you've said, you do see this exodus after doctors finish their initial foundation years as junior doctors, and of course some of those doctors do come back. But the point is that the government's been introducing policies which are essentially bringing in worse pay and conditions for doctors, and of course redesigning the workforce is part of this much bigger picture of privatisation that is going on. And if you think of the NHS as actually one of the biggest employers globally, it's not surprising that we're seeing this redesign to essentially shrink the workforce and to bring in worse pay and conditions. And where private companies have won NHS contracts, we have occasionally seen that. We've seen staff transferred to worse conditions compared to the NHS contract.
The irony of this conversation, I'm in the middle of a coughing fit. I feel like I need a doctor locum or otherwise. To remove myself from the situation. Jonathan, please carry on.
Scream if you need any help. So Dr. Coles, we've talked about the issues, we've touched on the solutions. What do you think needs to be done next? How would you like to see things progress so that we don't get these scenarios?
Sure. Well, we're already spending 117 billion on the NHS, so of course we have to cut costs. I mean, charging patients is one solution. Another one would be look at how many managers. I mean, it's called extreme manager realism. There are 48,000 managers in the NHS, and there are only 89,000 consultants, 67,000 GPs. Why do we need so many managers? We functioned well 10, 20 years ago, and in fact, if you look at a scenario, for instance, if you have to cover an orthopaedic department at a hospital and you have 6 junior doctors, they used to talk among themselves and cover shifts, holidays, sick, etc. But now everything is done through managers and it gets so complicated, and if they can't find a locum, then the doctor who's worked 12 hours is asked to work another 4 hours, and they might have children to pick up. So it just makes things more complicated when you throw in managers, when actually the solution can be a lot simpler if you just have doctors take care of their own departments, nurses take care of their own.
Dr. Youssef, is that something you would agree with?
That's exactly what used to exist before privatisation started. So management was one of the first things that was introduced as part of, by Thatcher, really under Thatcher's government, as part of this drive towards converting NHS into a market system and into privatisation, which has been a huge failure. So if we restore the NHS as a publicly provided and run and owned healthcare system rather than the system which it is now, which is a market system and it's increasingly privatised, then absolutely we should have doctors, nurses, NHS staff, patients and communities running their healthcare services. And that's, I think, the optimistic and positive vision for 21st century healthcare, rather than a privatised and eventually two-tier system with increasing private health insurance, which would be very retrograde.
Okay, Dr. El Gingihi and Dr. Coles, thank you both very much indeed. Sarah Jane, you have a sip of that.
Yeah, is it hay fever season already? Yeah, I think that might be what it is. I've had a tickle in my throat for the last 3 days, and sorry, it caught me out today.
Take the rest of the day.
Sorry about that. But the shocking thing about that debate was £70 an hour if you're a consultant. Do you know how much my car mechanic charges? 60. He charges £60 an hour, and a consultant gets 70.
It's incredible, isn't it? Well, do continue the debate online on Twitter.